psychology always intrigued me, and it was really the question about, why do people have schizophrenia, and really getting to experience firsthand what someone experienced when they had schizophrenia and the delusions, and it just was so fascinating to me.
Hello, and welcome to another episode of Buzz and Behavioral Medicine. I'm excited to bring you this new episode where we're talking with Dr. Karen Emmons, a professor at Harvard School of Public Health. Dr. Emmons is a giant in the field, and she has spent over 4 decades advancing cancer control research. But her journey was not always so smooth. Most interesting is her jump from clinical psychology into public health. I'm sure you're going to enjoy learning how she overcame early challenges to rise to success. Well, great. Thank you for joining us today, Dr. Emmons. It's great to see you and hear from you today. Part of our podcast series here is learning more about the scientists behind the science and learning more about your professional journey and your personal journey into behavioral medicine and some of the work that you've been doing. So we're glad to have you here today to talk a little bit about those issues. Let's just really, start from the beginning. You graduated with a bachelor's degree in psychology from the University of Illinois at Champaign-Urbana. So how did you end up on that path in going to undergraduate school and deciding in psychology?
Well, first, let me thank you so much for inviting me to be part of your podcast series. It's such a great idea, and I really appreciate the opportunity to chat with you today. So I grew up in a little tiny town in Illinois called Manteno. We used to joke about it being the suburb of Kankakee. A little tiny town next to a slightly less little tiny town, about an hour south of Chicago. But especially in those days, it was just a world difference. Really, literally, had classmates who, when we were in school all throughout, would have to leave in the fall to go help with harvest. So it was really very much a farming community. And the one industry besides soybeans and corn was a large state psychiatric hospital. And and this was back in the days of large scale institutionalization. And my dad was a psychiatric social worker, and so he was worked at that hospital for most of his career. In fact, I probably shouldn't say this in a public way, but my sister and I were both born on the grounds of the state psychiatric hospital. We weren't born there. We were born the next town, but we grew up there for the first year or two of our lives when staff lived on the grounds. So they were staff cottages. And so this was very much a part of our life. It was a minimum security facility. So people freely came and went, and it was really like a small city. It was our town was 3,000 people, and the institution was 10,000. So it just gave you a sense of the scale of the residents there. So it really, it was sort of psychological disorder was part of my growing up. I spent a lot of time in the best possible way. We spent a lot of time at the hospital with my dad. We would go out and bring him lunch, sometimes stay with him when there were events, social events, we would attend them. And then in high school, I did some internship work there. And it just, psychology was always intrigued me. And it was really the question about, why do people have schizophrenia, and really getting to experience firsthand what someone experienced when they had schizophrenia and the delusions, and it just was so fascinating to me. So I think it put the psych bug in my head, having all those experiences. But I went to college thinking I would become a doctor, and I was pre-med. It took about 20 minutes in my first, chemistry class to say, why would I want to do this? And so pretty quickly, I really realized that psychology, I was taking an intro psych course, and it just, that path I think had been set before I realized it. But so that's how I got started.
Well, that's really interesting. Yeah, those state psychiatric hospitals employed a lot of people in those small rural towns, and they were part of the community, as you mentioned. And it was almost like in some ways, there was some family business to what you were doing in terms of your dad being a psychiatric social worker, you mentioned. Did he mention wanting you to go into social work or psychiatric, or was it pretty much the exposure over time that kind of put you in that direction?
Yeah, I think it was exposure over time. There was never any pressure to go in that path at all, and I think he was totally fine if I wanted to go to medical school. My sister was in medical school when I went to college, and so it was sort of like, if you want to do that, that's fine, whatever you choose. So my parents were really, find your path and do it well and do it strong and take that path. So there was not a specific area, but it was, it was quite a intense exposure. I mean, I remember when I was a kid, I'd wake up sometimes on a weekend morning in the summer and, be in the kitchen making a piece of toast, and I'd look out on the patio and there would be a resident from the facility sitting on our patio because they would find their way into town, and everybody knew my dad. He was a leader in the institution for a long time. So, it was just part of our lives. And so the questions and the comfort of dealing with psychology and all things psychology was sort of ingrained in the beginning.
Oh, that's really interesting. And so then you went to undergraduate, and then how did you decide you shifted from pre-med? I thought you were going to be a doctor. I guess the next natural step was to say, okay, well, maybe I'll be a doctor in clinical psychology. Was that kind of the way it transpired?
Yeah, so I was at University of Illinois. I wound up in the honors psych program, which was research, and had the great good fortune of working with Doug Bernstein, who was one of the early leaders in smoking cessation treatment development. And, he was very clear, like, if you're going to go into psychology, you should get an advanced degree. That's, what one should do. And I kind of thought I would be a clinician. I thought that I would lead probably clinical researcher. In those days, that seemed, easier than I think it actually is. So I did research with him and decided, that was the right thing to do. But I didn't get into very many graduate schools. I applied to, I don't know, some normal number, 8 or 10, my first year out of college, as I was graduating college, and I got into one, and it wasn't really where I wanted to be. So I stayed for a year and taught intro undergrad, like 157 sections or something. It was just an enormous amount of undergraduate teaching. I learned a ton about people management in that, especially since I had a lot of football players in my class. So I really learned a lot about how to manage people and manage the classroom dynamic. Interestingly, I probably learned more in that year than I did in all the rest of my teaching experience. So I didn't get in the first year, and then I reapplied. I did more extensive research that year, and then reapplied and got into lots of places. I share this story because I think it's just really common and important for people to know that you can have a really successful career but have bumps along the way. And I had bumps in the beginning and could have gotten deterred, but was fortunate that I had someone in the background just saying, don't worry about it, just keep going and do this. And okay, so sometimes listening to advice is the right thing to do. So.
Yeah, no, that's so right. That experience is so common, and I think when you're going through it, you think you're the only one. I mean, it happened to me too. I didn't get in the first year, but I mean, it's so common, an experience. But when you're going through it, it's like, am I the only one that is not getting into clinical graduate school or graduate school in general? But it's important to persist if that's your passion, right? In graduate school, you went to SUNY, and there you also continued in the area of tobacco research or smoking cessation, or was it a little bit of, it was more broad, I assume?
Yeah, I went into really kind of the addictions area. Worked with, was very fortunate to work with Lorraine Collins and Gary Widener. Lorraine her area was more in alcohol addiction, but was able to do a lot in the tobacco area. And then Gary did a lot of work in cardiovascular impacts and cardiovascular reactivity. So was able to kind of look at the intersection of tobacco use and some of the more immediate cardiovascular sequelae and pulmonary sequelae. So when I got there, I started working with Lorraine right away, but I really thought I was going to be a clinician, strong clinician at Stony Brook. It was a standard clinical psychology training program, so there was a student clinic, and we started seeing patients, I think, in our second year, maybe shadowing the first year and second year having your own patients. And I just remember sitting in a therapy session, and we had excellent supervision, so I knew that somebody had my back. But I remember listening to this woman from the community and thinking, oh my gosh, you really have a lot of problems. You should really see someone. And then I realized that someone was me. And oh, this is not good. This is really not good. So, I continued through it, but after well into the first year, I realized I was not going to be a clinician. I don't have the patience for it. I don't think I have the talent for it. But research, thinking of questions, answering questions in a scientific way has always been something. I think I'm organized. I'm kind of methodical as a person. So you kind of figure out what are your personality traits and how do they match up with the requirements of a job. And the research always interested me. I always, lived for this sort of, the process has always worked very well for me. So.
Did you get licensed or no? Or
I did. I got licensed and I went to internship and I did the whole thing because it seemed like this far, I may as well do that. But I knew going into that I was not going to have a practice. I was not looking for jobs that required me to have a clinical component. I've used my clinical skills a ton, do intervention research, and so much a core of our behavioral interventions are really, of course, laid on a clinical psychology foundation. So I feel like I put the degree to really good use, but I've done it in a research capacity.
And do you remember some of those first research studies that really fascinated you? Was it the developing evidence-based interventions? Was it trying to understand the phenomena that relates to addiction? What was it that really drove you in that research direction?
Yes, it was kind of all that. It was all that. I mean, I really felt like, why people started picking things up, certainly addictions was very interesting to me. How people ignored signs that it wasn't good for their health was interesting to me. It was really that health, mind, body intersection that became very interesting to me. So one of the things that I did as my dissertation is I worked with both Gary and Lorraine and then someone who was a pulmonary physiologist. And one of the things that was interesting is this observation that, and we were in New York, and a lot of people, of course, commuted into New York City. And at that time, air quality was much worse than it is now. And so, you had people who were smokers who were exposed to lots and lots of air pollution, and they responded very differently than people who were non-smokers. And they also had a different response when they quit smoking. They became more aware of the pollution and their exposures, and in a way that it felt negative for their health. So it kind of added to this withdrawal complex. And so we studied to see whether or not that was actually a phenomenon. So I had the great opportunity to, this advisor had an ozone exposure chamber laboratory. And so we were able to study what happened as people quit smoking, to their physiologic response to different amounts of ozone, to kind of mimic what they were experiencing as they would be quitting in the natural environment. And so it was just, it was really fascinating to me to bring those two pieces together again, try to figure out some interesting challenges. And that was a space nobody was working in. I think one of the best pieces of advice I ever got, and I'll share this because I think it was so poignant. One of my early colleagues and bosses at the Dana-Farber, when I moved to Boston, was Fred Lee, just a wonderful, wonderful genetic epidemiologist. And Fred basically came to me and said, I've been doing a lot of work in childhood cancer survivorship. And one of the things that I noticed is that these kids smoke at a reasonably high rate, just like their siblings and, non-cancer survivors. And would you work on that? And I hadn't worked in survivorship. I didn't know anything about it. And I was kind of like, that's interesting, and started to explore it. And he said to me, Karen, always stand by the lamppost. You're in a dark street and there's a lamp, a street light, and look at the bottom of the lamppost where the arc of the light is and move out of it. And that's where you should study. And I thought that was such great advice. I tell my trainees and students that all the time. Don't go where everybody's going. Take a look at the side and think about the questions that nobody else is thinking about. So it's great to be in the thick of all the, whatever the thing du jour is. But, if you're looking elsewhere and it has meaning to it, you might be onto something. So that's sort of always been, I didn't realize it at the time, but I think in my early work and then later, I've always tried to look at a little bit of a different space because that just seemed a good place to be.
Yeah, that's really interesting. So, that idea of, having colleagues that are outside your field also shed light on other areas of research that could be really, really important.
That's one of the reasons I moved to Boston. And I think it is such an excellent point you just made. And that is that, we can surround ourselves by people like us, and we're going to get influenced by people who think like us. And one of my early studies as an assistant professor, I was at Brown, was looking at smoking cessation among pregnant women. And what I was really interested in was trying to reduce the baby's exposure. So we were looking at women who were towards the end of pregnancy and had just given their postpartum. And we wanted to see if we could reduce the likelihood that these kids were going to have heavy exposure. So I partnered with a wonderful environmental health person who had developed passive monitoring devices so we could measure the environment the babies were in. And we did an intervention with the parents, gave them feedback about what the exposure levels were. But I was recruiting women from a community health center, and I was sitting in the waiting room of a community health center, recruiting patients there. And I was talking to these women and getting to learn more about their stories. And I found myself sort of saying, woman after woman, undereducated, underemployed or unemployed, living in an unsafe circumstance, a variety of what we now know are social determinants. Then we weren't talking about it like that. And she smokes, and I pick smoking. This is dumb. And so that was when I really started to realize that that I needed influences, because I was talking to my colleagues, my wonderful, wonderful colleagues at Brown, but everybody's like, yeah, that's terrible that, all these things are happening to people, but nobody had a frame for it. Nobody, because everybody was trained like me. Everybody thought like I did. And so I was really feeling, probably this was maybe 6 years into my, being an assistant professor, and I was 5 years, I guess, and I was really feeling a little bit of a crisis. Like, I don't know what else to do because I've got these tools, and these tools aren't enough. And I happened to be in a cab coming back from a national meeting in DC, going to the airport, and Gloria Sorensen, who's a wonderful colleague and who hired me at the Dana-Farber, said to me, I really enjoy watching you in these meetings. You're really talented. We have an opening. Would you consider applying to, come up and work with us in public health? And I said, yeah, sure. Happy to talk about it. And we exchanged information and, note to self, find out what public health is. I had no idea what public health is. But this is a long-winded way of saying that I think exposing yourself to colleagues who work in environmental health and who work in, a whole range of different fields, for me, has been the lifeblood of my work, because I would have run out of ideas a long time ago. And by hanging out with people who don't really know what I do and don't understand psychology has helped me be a better scientist, I think.
So that kind of made your transition from more of a clinical psychology background, doing research with individuals, to then thinking about how does the individual fit within the context, and how does public health inform how we can, change behavior. I'm getting that sense from what you just discussed, right?
Exactly. Yeah.
And is there some things that you think, I wish I would have done some things a little bit differently back then, maybe learning that lesson earlier?
Yeah. One thing I didn't do is I didn't do a postdoc. I went from, did my internship at Brown with David Abrams and a great group there. And then being a Midwesterner, I married a New Yorker. So we had this really interesting sort of, culture clash. And it was sort of like, where are we going to wind up that, we can both manage? And we loved the Chicago area. We were looking at jobs in Chicago, but our first jobs after graduating were in the University of Illinois School of Medicine, but that is not in Champaign-Urbana or Chicago. It's in Peoria, Illinois. And it is not. It is kind of the middle of nowhere. And no direct road to get to Chicago, so you have to like go through the cornfields, and it's just for us. It was just not the best fit as individuals, and so we were there for a year, and so it was the longest year of our lives. We knew about an hour after we got there that we were probably not in the right place. There wasn't much of a research infrastructure there. I think they've really worked on that now, but it wasn't a good fit for me, career-wise, or for my husband in terms of lifestyle, being a big city guy. So we applied for jobs, and basically there was an opening at Brown, and I did my internship there, and had the opportunity to go back there. And I really wondered, though, if I hadn't done a postdoc, if I wouldn't have been better able to manage that career transition. I think that probably would have been a better thing for me. I'd have a fair amount of research experience, had written grants, had gotten grants by the time I got out of grad school. So I felt like I probably didn't need it, but I probably did. So my CV in my early days looked really bizarre. It looked like, I had grants and very few papers until well into my first few years of being an assistant professor, because it took me a while to get the papers and the grants. And so I kind of did a little backwards. So that was probably not the best advice. And I do advise all of my doctoral students to really try to do a postdoc. Many think they might not go into academics, but I still encourage them, even if you think you're going to go to work for a health department or CDC or somewhere else, do a postdoc, because it's hard to go back and get those skills and get that time, that dedicated time you have to thinking about your questions and framing your research.
Yeah, I think it does help. And you're a training director for a postdoc. I know that. And so I think it does help to sort of, like you said, take that time to really think about what values you hold important and how you want your career to progress. Obviously, there's a lot of different paths. You took a path, and it's led to your success. Let's talk a little bit about your work. You've been doing work in tobacco control. You mentioned a little bit of work that you did early on. You've done some work in smoking cessation interventions. You mentioned pediatric cancer, smoking cessation and pediatric cancer, and smoking prevention, secondhand smoke exposure, workplace wellness, and smoke exposure. Tell us things about that work that you've really enjoyed. And how has that sort of transitioned into some of the work that you're doing now that's more community-based and implementation science?
It's funny. I think I started with my work in tobacco and found my way to cancer prevention. So it was, I had the opportunity, as I said, as an undergrad, to work with this amazing professor who worked in tobacco. I didn't go into that thinking, oh my God, I really want to work in tobacco. Sometimes people draw you in, and you want to, learn from them and be with them. And so for me, that was really the start of why I went into tobacco. Just really was a great professor, and I enjoyed him and knew I would learn from him. So that then developed over the years. It was, for me, what tobacco did is it allowed me to understand that intersection between individual and broader contextual factors, more macro level forces. I mean, if we didn't have an industry that was devoted to selling a lethal product, and we didn't have politicians who were, willing to, support that at the detriment of our communities and our population, we wouldn't have smokers. And so that intersection has been quite interesting to me. And so thinking about, as I really developed my understanding of that, kind of thinking about what are all of these more broader social contextual forces that impact on people's health and their ability to engage in their health well, and how do we really think about how these all go together? I think we did some of the early work with David Abrams and Gus Marcus and others, looking at multiple risk factors, and in workplaces, how do we reduce people's exposures to environmental carcinogens, including tobacco, but others as well. And Gloria and Sorensen did a lot of work in this space, as well as try to help them be more physically active. And can you start to measure these as they go together? So really thinking about not one-offs, but how we really put it all together. So it all seems kind of fluid now. I guess it probably wasn't at the time, but that once I realized and started to understand and have a frame for the broader contextual factors, it helped me really understand the opportunities we have of thinking about environment, shaping environments differently, and really, policy and approaching things at a much broader level, while also making sure that individuals have access to treatment, they have the knowledge they need to utilize treatments. This is such an interesting space in the public health world. I think a lot of our doctoral students come in really having, I'll say reacted, in parentheses, overreacted to the idea that for so long, public health structures were really focused on individuals and did not focus, as we know they need to now, on more structural factors. But so it's become a little bit of this, so we can't do anything with individuals. We should leave individuals alone and only do, choice architecture and only do behavioral economics. And, I don't think there's ever a time when we should say only. As scientists, I think it's probably always going to be both and. And so in my course, I teach a health behavior theory course at multi-level. And I really start with macro theories and then work my way down to individual and then work back to putting it all together. And I do that because in public health, people come in really loaded for bear against the individual orientation. And so the first year I taught, it was a disaster. And students were like, we shouldn't be talking about behavior, and behavior is a bad word. I'm like, what are you talking about? In the end, people have autonomy, they have choice, and everybody may not have as much autonomy as you would like them to because of their context. But in the end, we should never be saying, now we're starting to sound like, the police state will determine what happens to individuals. It just, we have to understand that people are always going to have autonomy, regardless of how, structured, how the environment is structured. So I think I finally figured out how to get the points across. But I think it's so important to understand that whole continuum and to consider that whole continuum in everything that we do.
Yeah. And I think some of your more recent work on implementation science is also sort of how do we move that into practice and how do we expand that multi-level approach to be sustainable. Is that kind of what you're thinking about in those areas?
Yeah, so I was so fortunate. I have been really lucky in my career that sometimes things just happen at a moment when it's possible to sort of go, oh, look over here, and kind of go down a path. And one of those paths was implementation science, and the wonderful team at NCI, when Barbara Reimer was the director of the Division of Cancer Prevention and Control, Bob Hyde, Bob Coyle, they started really doing a lot of thinking about implementation science long before I think many of us had, and they started to really push this idea of how you design for dissemination, and then that sort of morphed into implementation science. John Kerner was the first implementation science deputy director, and so they have these supplement grants for R01s that were to focus on implementation of an evidence-based intervention. And we had done this work in cancer survivorship and tobacco for childhood cancer survivors. And we showed that we were able to double the quit rate. And we used a peer-delivered intervention, a telephone intervention. Again, this was a long time ago, probably 20 years ago now, when that was sort of novel. We trained survivors and how to do brief counseling, and we had tailored materials, and we provided nicotine replacement therapy. And so we thought, hey, there are survivorship programs all around the country, so let's try to use this as an opportunity to disseminate that. And I'll give you the short version of the story. We developed this wonderful set of materials and processes, and this should just sit right in your clinic, and should be perfect. And we got no clinics that enrolled a single person. And I have a wonderful slide when I give talks on this, a party room with one person sitting in it all by themselves, and that kind of was what it was. Is we threw this party, but we did everything wrong. We didn't understand about workflows. We didn't understand about how the healthcare delivery system actually works, and this hubris of, oh, look, we have this amazing shiny thing, and now you need to just use it. And there was great intent on the clinic side, the survivorship clinic side, they were very enthusiastic and excited about it, but we didn't do the work we needed to do to adapt what we had done to their setting, to bring them along, to get their voice, all the things that we know now we do. So that really, sparked my bug for, and also as you get older, you start to think, what am I leaving behind? What is my legacy going to be? And, a lot of interventions that nobody uses, that was not so, looking so pretty. So that's where the implementation science piece really started, along with, cancer disparities has been something I've been, deeply concerned about for such a long time, and really starting with the early tobacco work and, looking at how social position really drives health and health behaviors. So it gave me an opportunity to really think about more deeply how we work with settings that serve populations that have been marginalized historically, and how we think about these under-resourced settings. And many of us, I think, are very lucky to work in well-resourced environments. Or we have the ability to get grants that allow us our work to be well-resourced. But we don't really think about what that's going to mean to these environments that we want to take this up. And what often happens is that then our interventions work well for well-resourced environments, which, what does that do? It just drives disparities. So we partnered in the last 5 years, this wonderful organization in Massachusetts called the Massachusetts League of Community Health Centers. They're the Primary Care Association in Massachusetts. And, we've just been able, through wonderful funding from the NCI, to be able to really start to study, how do you implement in low-resource settings? How do you develop and adapt interventions that work in these settings but still are effective? And most of our work is really at the systems level now. We're not enrolling individuals. We look at aggregated patient data. But I think for me, for what we're doing right now, we need to pay attention and understand what the issues are facing an individual as they decide to get cancer screening or whatever the issue is. But so much of it is driven at a broader level. So that's really, for us, been a really driving force, is trying to understand the resource ability and engage people in the kind of science we do. And it's just been so amazing watching these clinicians and, community health workers really everybody wants everybody to have access to what they need and what we all should do. So trying to make that all work has been really great.
Yeah, it's a very exciting time, I think, in our field, where we're trying to think about how do we involve community members in helping us figure out how to help improve health in their own communities. And that sort of hasn't been something that's completely worked out. It's still, we're still trying to figure out, how do we do these multi-level interventions, and how do we implement things? And those early failures of yours and your colleagues and others and many of ours has taught us to take a step back. Let's develop some ways of thinking about this that will help future generations.
Yeah, I think all this work that's happening now in co-design is so exciting. And it's not just about, hey, you want to help me design something? It's like, what are the principles of how you bring different ideas forward, and how do you facilitate that process well? And I've been so humbled and impressed by one of my colleagues, Becca Lee, is someone her facilitation skills are second to none. And watching her navigate our co-development processes, we co-lead our community engagement program for our CTSA and Clinical Translational Science Awards, alphabet soup. And we, having someone who can live in lots of worlds simultaneously and understand perspective, I learn from her every day. And it is I think that's the other part about how you develop your teams, is bringing people on teams that allow the team to have broad skills, knowing that not any one person can have all those skills. She's much more from an applied perspective than I am, and I'm never going to have the depth of knowledge about how to work with community that she does. Even though I worked with community for a long time, she just has a natural talent that I don't have. And so together, I've learned a ton from her. And that's a really important part, I think, of putting your team together, is being honest about what do you have and what don't you have, and giving space for others to bring what you don't have and lifting that so that the whole team benefits from it. And it's not about, again, the individual, it's more about the whole team function.
So SBM's really been your home for many years. You mentioned, being a part of SBM. You actually had I think you had an Outstanding Scientist Award early in your career. No, an early Young Investigator Award in SBM. And then President, and then Outstanding Scientist Awards. And you've been a mentor for many people throughout SBM. It's been your professional home. What is it that you enjoy most about SBM that keeps you coming back? There's a lot of different conferences, organizations, but you've been a part of SBM for many years.
Yeah, I sure have, and I've benefited so much from it. It's the first professional organization that I joined, and the only one that I've been part of my whole career. I've dabbled with others. I find SBM, first of all, there's just so many like-minded people there and wonderful people. I mean, people, kind of sounds a little cliche, but it really, the people really draw me back. And, my trainees go there, and it's a place where I just see people that have been part of my career, my whole career. And I just, people who've mentored me still come, and people that I mentored. So that is kind of full circle. And I really, really appreciate and love that. I also think it's an organization that we've stayed not big. I mean, I think we're getting bigger, right? We're not small. But I appreciate that we're an intimate organization. And, you can pick up the phone and call somebody in SBM, even if you don't know them, and probably get a response. It's people that I feel like it's a manageable, having gone to the American Public Health Association meeting, others that are, in APA, it's just like, you could go that whole conference and not see a person that you know. And the relational aspect. And then I learn from my colleagues, and I think people do interesting and creative work. And we give junior people a really nice pulpit. I think SBM really does give junior people an opportunity to present and get, helpful feedback. And so I think there's a lot to it that we've really developed over the years that make it for me really just a wonderful, wonderful professional home.
Well, this has been wonderful talking to you and learning from you about your professional journey and some of the science you've been doing. I just want to kind of wrap up and end by talking a little bit about some of the advice you might give people at different stages of their career. And we talked a little bit about that, but if you want to have a minute to kind of encapsulate that, what would you tell people that at early career, mid-career, or senior career stages, what advice would you give them that you've learned? Lessons learned, I guess.
Yeah. Well, I think, it's sounding so cliche. I think passion is really important. And so I guess at every stage, it's sort of, figure out what your passion is, what really interests you and drives you, and try to focus on that. I think at the early career, one of the most important pieces of advice is understand that you have a long trajectory ahead of you to answer the questions you want to answer, and think about it kind of methodically. You don't have to do everything at once. And I see sometimes junior people now, especially that there's, we've lifted up, social determinants and these, more contextual factors in a way that I think it brings an urgency to try to fix these things, which I totally agree with. We're not going to do that overnight. We didn't create these problems overnight. We're not going to solve them overnight. And so I think that sometimes I see young people getting frustrated at what can be a glacial pace of change, but I think it's really important to recognize that if you think carefully about what is the whole, what's your theme of your research, and what are the component pieces, and what are the questions you have to answer at each step of the way, break it down makes it a little bit easier, I think, to accept the slower pace, because you can't go from here to there. So what are the component pieces, and how do you really focus yourself on those? So I think for early people, that's important. For mid-career people, I think it's really important to understand pacing and, balance. And it's so easy to get caught up in, just work, and all that entails. And I think we as a society, we are a group of people who are overachievers. I mean, we really are. We have just tremendous success. We have people who are really striving in the best possible way and want to make a difference. And I think it's super easy to get burned out. So I think it's really important for people to take pace, not compare themselves to others, but compare themselves to, themselves and, where do they want to be and how do they get where they want to go? And so I think that's really important advice. And probably for people in the later stages and maybe middle too, for me, it's really about, how do you pay it back and pay it forward? How do you really think about, helping people in their transitions? How do you pave the way more effectively for other people? And really think about bringing up the next group, and SBM, I think, has done such a really good job on that. One of my dear friends got promoted at Harvard, many, many years ago. And I attended his the party, and I happened to get there a little bit early, and he was sitting by himself at the bar in this restaurant, and I went up and I said, Professor so-and-so, now that you're promoted at Harvard and you're a full professor at Harvard, what are you going to do? You're going to go to Disneyland? And he said, I'm never going to be first author on a paper again. And I thought that was I just really I thought, wow, yes, that's right? Like, serve yourself and your team, but serve yourself when you need to serve yourself. And then when you can shift it and when it doesn't matter anymore, don't make it important, right? So when you get to a point where you've achieved what you can, be generous. Help other people. Turn it away. It doesn't help me to have more first author payment. And sometimes I have to, and sometimes I do, and sometimes I want to, and I'm going to be, fine. But think about it. Don't just get in the rhythm that I'm the leader and therefore I'm going to do this and I'm always going to be that. Really be generous.
Well, you certainly have paid it forward in our interview today. I appreciate you paying it forward today and helping us learn a little bit more about your career, your path. And so thank you again for doing this with us today.
It was really fun. Thanks so much for having me.
And that brings us to the end of another insightful episode of SBM's Buzz in Behavioral Medicine. A huge thanks to Dr. Emmons for sharing her journey and wisdom with us. Be sure to check out the show notes for links to Dr. Emmons' articles and relevant SBM resources. As we reflect on our conversations and anticipate the future of behavioral medicine, remember, it's our collective drive, passion, and curiosity that will shape the course of the future of behavioral medicine. I'm Dr. Bernard Femler, reminding you that behavioral minds matter. Keep doing the good science you do and the science that does good. Remember to like, follow, subscribe to receive notifications.